Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the organizing committee to give me the chance to be a speaker among the first immunology and allergy conference in Emirates. Thank you. So our talk, it's atopic dermatitis. As my colleague, Dr. Ahmed Al-Bahri, he mentioned a lot for the slides. I will come across and talk about it also in my slides. So atopic dermatitis, for us as a dermatologist, we have, in my clinic, I have 10% of my patients, they are atopic dermatitis. And it is the same like the other, I think, respirologist and asthma, it's similar with the IT, also allergic rhinitis. So the background of these diseases, actually, it is similar, but the pathway, it is different in these diseases. So we are almost the same. So the atopic dermatitis is the known chronic inflammatory disease. It has epidemiology, it's about in the adults 3 to 7%, while in children it's a high percentage, which is 15 to 25% of our patients are actually it is children. 1/3 of these patients of atopic dermatitis, they have moderate to severe. We have to dig actually in the severity of the disease itself in atopic dermatitis, because we will come later on in the therapy of this special group actually. It is not the mild to moderate cases in a systemic therapy. So there is an unmet need, I said, as I mentioned, in a moderate to severe group of atopic dermatitis. So what is the main reason behind having such patients? There is a lot of controversial, actually. There's a genetic, environmental factor, external factors, organism, bacterial, infection, viral, all these actually play a role in atopic dermatitis. The main symptoms these patients actually, they suffer from is a dry skin. And this dry skin actually, it's increased in the seasonal time, in the winter, and the elderly patients almost they have dry skin. And also if our humidity is low, these patients also, they suffer of a severity of symptoms in atopic dermatitis. Especially there is also other factors, which is the detergent they are using, actually it may affect their skin outcome and their symptoms. Plus the other fabric used, like a wool type of fabric, it also affect the skin. The skin, it's like a wall. When it will break, the bricks break. So all these external factor will affect the skin integrity and will lead to the cascade of the immunological factors and inflammatory cells later on. So there is a debate actually in the atopic dermatitis. Is it a barrier defect or it is immunological factor there? So still until now, there is no definite answer actually. Is it a barrier defect? Genetic background with the effect of the barrier, or there's immunological factor in this matter. So still until today, they couldn't put a clear cut between these two. In a normal skin, as a dermatologist, as a normal skin, they don't have any changes in the epidermis. So it's a normal epidermis with a few T cells present in the normal skin. But actually, in the atopic dermatitis, there's a big changes in the epidermis on the skin. So the epidermis, and there will be a huge of infiltration, proliferation of T lymphocytes, which lead to increase the other cytokines and edema of the skin and the epidermis with the spongiosis and proliferations and hyperplasia of the epidermis, and the integrity of the keratinocyte will be affected and it will be not regular. So this is how they manifest the patients with atopic dermatitis. Their skin is weeping, eczematous, and it have lichenification, excoriation. So it looks like there is an itch in these patients. This is another manifestation of the acute form of the skin manifestations of vesicular papular rashes in this patient. So these patients are actually suffering. It's like asthmatic patients. These asthmatic patients, they have difficulty in breathing. They cannot sleep, especially an allergic rhinitis. They have a lot of running nose, especially it's a running nose in other way. It is in the skin itself. These patients, they have itchings, they cannot sleep, especially if they are children. All the family, they are awake all the night, they don't sleep because their child cannot sleep from the itchiness. So there is an unmet need for specific therapy in this group. This is another manifestation. From the studies, they couldn't differentiate actually histologically from the psoriasis and atopic dermatitis. Both of them, there is a proliferation. Both of them, the marker of the proliferation of the epidermis are similar, keratin 16 and Ki67. Both of them is present as a marker in both sides. As a dermatologist, when we are sending biopsy for the skin, it came back, it is psoriasiform dermatitis. Histologically, we cannot differentiate between these two diseases. What is special in atopic dermatitis, if we compare to psoriasis, the T helper 2 and T helper 22 are the more centralized manifestations in atopic dermatitis. Actually, what is different between these two groups, that even the normal skin of atopic dermatitis patients, they have these inflammatory molecules, which is increased, although their skin is normal. So it is a systemic proliferations of inflammatory cells, even in normal skin or other sick lesions. What it comes also nowadays, they dig the researcher, and that something is called TSLP. It's a thymic stromal lymphopoietins, which is involved, we have seen it is involved an increase in the skin of the patients is having atopic dermatitis, which is released from the epithelial cells of the keratinocytes in atopic dermatitis patients, which is related to the external exposure of either organism, trauma, or radiations, viral infections, or any other these factors, environmental factors. Increase the TSLP. TSLP will be activate the immature dendritic cells, antigen-presenting cells to become mature. This the mature dendritic cell will have a receptor. Nowadays, there's a researchers working on something called the OX4L, which is they are in a process to have a therapy for this receptor, to hit this receptor, to stop the cascade, to activate the T helper 2, and subsequently the cytokines release. TSLP was involved also for other diseases, the hematological diseases and other parts. And they found that there is a polymorphism in the TSLP, and it was high in allergic diseases like an asthma. So it is actually asthma and atopic dermatitis, they are sharing some immunological inflammatory cells. This is the same what Dr. Ahmed asked actually. He came across to it and showing that how the T helper 2 and T helper 22 are responsible from the inflammatory process and the cascade of how it will increase and inhibit actually the antimicrobial peptide, which is responsible from the protecting the skin from the Staphylococcus aureus infections. Most of the atopic dermatitis actually they presented with a secondary bacterial infection. This is due to that it is actually affected by the IL-13 and IL-4, which is released by T helper 2 cells. Another thing, which is also the IL-31, also it will be released by the T helper 2 cells, which also affect the itch. IL-31 is more responsible from the itch on the itch receptors. So these patients, they suffer from itches all the time. So it will lead to scratch and decarification, and the cycle, the vicious cycle will go on and on. And they will recruit more T cells and will recruit more antigen-presenting dendritic cells. These cytokines will pass to the JAK inhibitor, like what Dr. Ahmed mentioned, and he clarified in his slides and presentations that these cytokines will be affected, and the ligands will to the receptors, which is JAK protein present. We have 4, as you know, as an immunologist, we have the 4 types. The 3 of them, JAK1 to JAK3, and the 4th one, it is the tyronase kinase 2. and the cascade of the phosphorylation of the JAK-STAT pathway, it will pass to the, it will be cytoplasmic to the nucleus and the protein, and it will be presented and formed. So as a dermatologist, actually, before 2017, we don't have to treat our patients except cyclosporine, systemic steroid. Most of the patients, they're afraid from this, they have a phobia actually from steroid. When we are prescribing, we are prescribing mometazone and potent steroid. So until 2017, it came to us something called, it is biologic, dupilumab, IL-4 and IL-13, and plus phosphodiesterase inhibitor 4. It helps us. The phosphodiesterase E4, it is the topical type, crisoprolol ointment, and plus dupilumab. Dupilumab, when it came to us as a dermatologist, it was really, it's helpful for our patients. The first things, it helps us in the decreasing the itchiness. The patients, they sleep. They don't mind they having the lesions, but the itchiness is the main important point, which is the dupilumab actually affect the itchiness in such patients. And later on in 2021, we have a rush of biological therapy comes to us, affecting similar to what IL-13 and IL-31 plus the JAK inhibitor. The first JAK inhibitor, we have it before, it was tofacitinib, which is prescribed for rheumatoid arthritis. As off-label, we have been using it actually in the Alopecia totalis in our patients, which is affecting the JAK1, JAK2, and JAK3. But with the new JAKs, they are milder in form and less side effect we have seen in our patients when are using such JAK. Apremilast was mentioned here, but apremilast doesn't show the efficacy actually in atopic dermatitis. But recent studies, it was used with dupilumab to increase the efficacy to be more effective in atopic dermatitis. So these are the part where these biologics are hitting and blocking the pathway in the atopic dermatitis. So what is the difference between using the biologic and macromolecules, the JAK? Usually the biologic will not pass the cells itself. It will affect on the cytokines and the receptor itself. It's external, it's working. While the JAK, it is more going intracellular and affect and blocking the JAK receptor protein itself. So to block all the cascade of inflammatory process of the JAK-STAT pathway by phosphorylations and okay. What we are looking at our patients, we are looking at this picture actually. From clearance from the eczema patients to clear skin. This is a satisfaction from both sides, from the dermatologist and the patient side. So phosphodiesterase inhibitors, crisaprol is 2%. It's the first non-steroidal ointment topical was we receive it as a dermatologist, and it is novel actually to have it. It is non-steroid sparing therapy. So how this will work also? It will work by blocking the phosphodiesterase inhibitors, where cyclic AMP will increase, and accordingly the pKa protein kinase will be also activated. It leads to block the nuclear factor in the T cells and nuclear factor in the B cells. Accordingly, all the cytokines will be stopped from release. So there's a long-term safety actually we have seen from the using such medicine as a topical. The only side effect was mentioned by the patient. It is the burning and paresthesia sensation on the site of the application. This is the only side effect have been seen and from the treatment use. Dupilumab. Dupilumab is a nice medication. When it came, it was really wow in our treating our patients and atopic dermatitis, but still they didn't reach EASI 90. Only 38% of the population of the patients with atopic dermatitis, they reach only the EZ90. So there is still a gap that we have to fulfill using another modality to treat a patient. And there is a patient also, they have, before going there is difficult to treat area by using dupilumab. I will come later on to mention that. The only side effect have been seen in the studies, it is the conjunctivitis. The only side effect have been seen. But believe me, during my experience with dupilumab, I have a lot of patients in dupilumab. From even, the dupilumab is approved from 6 years and above. I have patients on 5 years of age. He's on dupilumab. He's quiet. He doesn't have any problem with it. But I have some patients still, they don't, as if the dupilumab doesn't touch their skin. Still, there is a persistent atopic dermatitis. I will go through quickly. As the organizing committee, they are telling me that's 2 minutes. So this is the conjunctivitis. I haven't seen in my patients. This is the clearance we are looking for when you are treating a patient. In asthma, allergic rhinitis, we need a clearance. In any symptoms, free of any symptom. This is what we are looking at as atopic dermatitis. Actually, this is the, when I said resistant area to be treated, the face, the hand. Dupilumab doesn't touch patients with a face eczema. This is a patient also. She received dupilumab, clear all the skin except the face. This is the gap of we need EZ90 in atopic dermatitis. So we are looking for further management. So emerging the JAK inhibitors, it comes and adds some value with us as a dermatologist. So this is the JAK. It is the JAK-STAT pathways with phosphorylation, dimerization, and gene transcription. So it was okay. There is another, because JAK, it comes in oral therapy, but there is an topical therapy, ruxolitinib also is available nowadays and approved by FDA. It's also effective in the atopic dermatitis, and there is another therapy, it will be used also for vitiligo patients. So it's a promising actually for vitiligo. Still in vitiligo, we don't have that much therapy approved as FDA. This is the studies and how it's affected, and also in almost similar, the topical here, and the percentage we have seen in the ruxolitinib with the dupilumab almost the same. So, what they call it? Tralokinumab, with a lot of names. Tralokinumab is an IL-13 inhibitors. Actually, it was examined and investigated when they are using the meningococcal vaccine and diphtheria with tetanus and pertussis vaccine. This is where, actually, as a physician, as a practitioner, we would like to know if these biologic will affect the immunological effect of the vaccine or like given in these patients or not. Actually, it's promising. So we can go ahead, we treat our patient with a vaccine, like it's a live attenuated vaccine, but not a live vaccine. It shows that in this studies, it shows that it's not affect, this biologic doesn't affect the outcome of anti-tetanus response. It was similar to placebo effect. So it is 91.9% and 96.1% in placebo. So this is a promising actually result. This is the same when we're going to focus.
Dr. Muna, please wrap up.
Yeah.
We can move on.
Done?
Yeah, okay. Can you just please?
I will close it now with the last comment that in COVID patients, actually they studied also atopic dermatitis from 2018 until present in US, and was a large cohort study. They found that the patient with atopic dermatitis, they have higher COVID infections. And was interesting that what they found, a lot of studies was done through this part also. They found these two diseases, they have interleukin 3 and interleukin 14, which is more interesting in that these two diseases, they share these inflammatory leukotrienes. So I'd like to say thank you.
Thank you very much indeed.